So let's summarize what we've learned in this chapter, and let's start with the left ventricle. The shape of the LV is important. The normal shape is that of a truncated ellipsoid. To quantify the size of the left ventricle, we can use diameters and volumes, and these can be assessed both with the M mode and 2D, basically with the so-called Simpson method. The function of the LV is more than ejection fraction. Myocardial mechanics are important, and the left ventricle is very strongly dependent on pre- and afterload. To quantify the left ventricle, we can use visual assessment, the eyeballing method. We can use the fractional shortening method, which is an M-mode method, and the Simpson method, monoplanar or biplanar. In addition, we have hemodynamic measurements, which can be performed with the help of Doppler, calculations of dPdt using the MR signal, and newer methods such as tissue Doppler and speckle tracking. The right ventricle is different than the left ventricle, both with respect to the anatomy and the function. Remember, we have a more longitudinal contraction of the right ventricle. We need special views to visualize the right ventricle. And the quantification of right ventricular size and function can be performed both using eyeballing, diameter measurements in 2D, area measurements, the so-called TAPSE, and tissue Doppler imaging. The left atrium is an important structure of the heart. It is a marker of disease and prognosis. We can measure the size of the left atrium with the M-mode technique behind the aorta, but also with the 2D technique using diameter measurements, area measurements, and volume measurements. The right atrium can be quantified very similar than the left atrium. It provides important information, or the shape also provides important information on RA pressure, and also pay attention to structures which are associated with the right atrium, such as the coronary sinus and the vena cava inferior and the vena cava superior. LVH is an important predictor of cardiovascular disease. The degree of LVH is related to mortality. It is a compensatory mechanism to an increase in afterload, in particular in patients with hypertensive heart disease, but also in patients with aortic stenosis. There are various different forms of LVH depending on the size of the left ventricle. To quantify LVH, we can use septal thickness and mass, which can be calculated using M-mode methods, 2D methods, and 3D methods. It is sometimes difficult to differentiate hypertensive heart disease and left ventricular hypertrophy from physiologic forms of hypertrophy, as you would see it in athletes, and other forms such as you would find them in hypertrophic cardiomyopathy or other causes of left ventricular hypertrophy.